Greetings, everyone. I, Dr. Arman Seth, a graduate from Maulana Azad Medical College, New Delhi, along with Dr. Balaji Dattatreya Shukla, also a graduate from Maulana Azad Medical College, have started a medical quizzing foundation called the Millennium Quiz Foundation. We will be organizing weekly medical quizzes comprising of important clinical questions from the entire MBBS course, which will not only help you cultivate an interest in quizzing, but also tackle questions in your entrance examinations and deal with challenging clinical scenarios in your day-to-day practice. We are happy to say that yesterday we organized our first quiz, and we are happy to share the solutions with you. But before beginning, I find it worth mentioning that both of us started quizzing in our third semester. And ever since, we have participated in hundreds of quizzes. And I can safely say that it not only made solving questions a habit for us, but it made the process so enjoyable that we never dreaded sitting in any examination. Therefore, we want to share our knowledge with you through our quizzes. And with this, we now begin with the solutions. So our quiz had 21 questions, and among that, this was our first question. So in this question, we talk about an entity that presents as subacute progressive encephalopathy with myoclonus and periodic triphasic complexes on EEG. What does this bring to our mind? Yes, CJD, Creutzfeldt-Jakob disease. But unlike CJD, there is fluctuation in the severity of illness in this disease, and this responds well to glucocorticoid therapy. So before knowing the answer, let's talk about CJD. CJD is Creutzfeldt-Jakob disease. Creutzfeldt-Jakob disease is actually a prion disease. Now, this is a disorder of protein folding. Therefore, in this, the proteins are misfolded. It presents as a progressive neurological deficit with myoclonus. The key word being progressive. Neurological deficits may be dementia, psychiatric symptoms, extrapyramidal symptoms, or cerebellar symptoms. But as I said, the most important term is progressive. And there are no fluctuations and there is no response to steroids. The EEG in this patient reveals periodic triphasic complexes. As you can see in this EEG, you can see that there are triphasic complexes. Now coming to the answer to this question, which was steroid responsive encephalopathy with autoimmune thyroiditis, also called SREAT. It was earlier known as Hashimoto's encephalopathy. The important point being that it is unrelated to TFT, that is, it can occur even with a normal TFT. It is an autoimmune vasculitis. Patient has high levels of antithyroperoxidase and antithyroglobulin antibodies, but these are not the cause of vasculitis. The cause of vasculitis is anti-enolase antibody. Alpha-enolase is an antigen expressed on endothelial cells, and anti-enolase therefore causes cerebral vasculitis, which then presents as subacute onset of confusion, altered consciousness, myoclonus, and it may even present as small vessel stroke. But the important point here is that it can present with a fluctuating severity, unlike CJD, which has a progressive course. It is worth mentioning that alpha-enolase is also an atypical ANCA target. ANCA is anti-neutrophil cytoplasmic antibody. And as we all know, P-ANCA and C-ANCA are found in various vasculitis, and therefore this also causes vasculitis. Treatment is steroids as it is due to autoimmune inflammation, therefore steroids are useful. Now my partner Dr. Balaji will discuss the next question with you.
Hello everyone. This question talks about the lymphatic status of the CNS. CNS is traditionally being considered to lack a classical lymphatic system, and immune privilege status previously been given to the CNS is only relative. Now we have found the two lymphatic structures in the CNS called as the glymphatic system and the deep dural lymphoid system. These causes the clearance of debris from the CNS and the responsible for the immune surveillance status of the CNS. The lymphatics are a distinctive architecture consisting of lymphoid-like structure and astroglial cells. These remove water from the brain interstitium. The deep dural lymphoid system, these consist of plexus of small lymphatic-like vessels on external surface of meningeal arteries and the dural venous sinuses. They drain into deep cervical lymph nodes and they clear solutes from the CSF.
Okay, now coming to the next question. Now here we talk about a disease which is caused by mutations in the GTP cyclohydrolase 1 gene, which encodes for a rate-limiting enzyme in the biosynthesis of dopamine via the biopterin pathway. This disease has its onset in childhood and it presents as a dystonia which shows diurnal fluctuations and shows a dramatic response to low dose of levodopa. The disease is dopa-responsive dystonia, also called Segawa syndrome. Now let's see why this happens. This in front of you is the pathway of synthesis of dopamine. The precursor, as we all know, is L-tyrosine. And the first and the rate-limiting step is the step in which tyrosine hydroxylase acts to convert L-tyrosine into L-dopa. The cofactor for this is tetrahydrobiopterin, which is converted to dihydrobiopterin. And GTP cyclohydrolase is an important enzyme required for tetrahydrobiopterin synthesis. Therefore, if it is missing, then there will be dopamine deficiency, which will present typically as dystonia. But it can also present with features of Parkinson's disease. And therefore, it is very important as it responds markedly to levodopa therapy. It is worth mentioning that this is an autosomal dominant disease, but it can also have autosomal recessive inheritance if it is due to mutation in tyrosine hydroxylase. As you can see in this pathway, a deficiency of tyrosine hydroxylase will also cause a similar effect as that of GTP cyclohydrolase deficiency. And it should be suspected in patients with less than 20 years of age presenting with features of PD, that is early Parkinson's disease.
Okay, coming to the next question. In this question, we are talking about myasthenia gravis and the treatment for this myasthenia gravis. We use a drug in the refractory cases of myasthenia gravis, which reboot the immune system and eliminates the mature lymphocytes, but spares the hematopoietic precursors because they express the enzyme aldehyde dehydrogenase, which hydrolyzes this drug. Myasthenia gravis, as we all know, is an autoimmune disease due to antibody against acetylcholine receptors. The treatment consists of immunosuppressive drugs, which can be classified into three categories. The immediate effects consisting drugs are the immunoglobulins IVIG and the plasmapheresis therapy. The intermediate effect drugs are steroids and the cyclosporine and tacrolimus. And the long-term effect causing drugs are the mycophenolate mofetil MMF and the azathioprine. For the refractory cases of myasthenia gravis, we have a new treatment known as cyclophosphamide, an anti-cancer drug, which reboots the immune system, as mentioned before. It is worth mentioning that in this INI-CET examination, the active metabolite of cyclophosphamide was asked, and it is the 4-hydroxycyclophosphamide.
Okay, so the next question talked about a fatty acid oxidation pathway defect, which causes the most common recognizable cause of recurrent myoglobinuria. It presents as muscle pain and myoglobinuria, typically after prolonged exercise, but also can occur by fasting or infections. A normal rise in venous lactate is seen during forearm exercise. So they're asking the name of the enzyme. The enzyme is carnitine palmitoyl transferase 2 or CPT2. Its deficiency is the most recognizable cause of recurrent myoglobinuria. Now, the important points are that the muscle pain and myoglobinuria occur only after prolonged exercise. If you compare it with the glycolytic defects like Mecardle's disease, this occurs after very short bouts of intense exercise. Also, it may be precipitated by fasting and infections, which is not seen in the other forms of glycolytic defects. And the last differentiating point is that there is a normal rise in venous lactate after forearm exercise in CPT2 deficiency, which is again not seen in glycolytic defects, as lactic acid will not be able to get formed.
So this is a direct question, which is asking about a score used to predict the post-operative nausea and vomiting. This score consists of 4 parameters: the female sex, history of motion sickness or post-operative vomiting, or a non-smoker status, and the post-operative opioid treatment. Each parameter consists of 1 point with score minimum of 0 and maximum of 4 points. The score is known as FL score. This is a direct table taken from the Bailey and Love, and we feel this might be a potential question for you.
Since you already gave a question on a score, we also mentioned another question on another important score. Given here are 5 scores, which are surgical risk scores for predicting mortality. All of these scores don't need intraoperative information except one. So we have to choose that score. So let's talk a bit about these scores. Surgical risk scores are of 2 types, those predicting mortality and those predicting morbidity. We are now talking about the scores predicting mortality. As mentioned, these are Donati score, Hartman index, Glasgow aneurysm score, Bowie score, Hasse-Tepe score, and Rees index. Hartman index and Glasgow aneurysm score are typically used for ruptured aortic aneurysm, while Bowie score and Hasse-Tepe score are used for perforated peptic ulcer. And the first 5 scores, namely Donati score, Hartman index, Glasgow aneurysm score, Bowie score, and Hasse-Tepe score, do not require any interoperative information, while the Rees index requires interoperative information. So it's worth remembering these scores.
In this question, we are asked about the treatment of aortic regurgitation. As we all know that aortic regurgitation can be due to the valvular defect, or it can be due to the dilatation of the root of aorta. Whether there is defect in the root of aorta, we have a treatment called the David procedure. This is the wall-sparing aortic root reconstruction procedure, and it is done in aortic regurgitation cases due to aneurysmal dilatation of root. You can see in the picture, the aortic root and the proximal ascending aorta are resected, and the sinus of valsalva and coronary artery buttons are mobilized. In this image, the next image, the subannular sutures followed by annular sutures are passed through graft and tied. And in the next picture, you can see the valves are reimplanted inside the graft and coronary buttons attached to the side of the graft. This is known as the David procedure, and it is used in treatment of aortic regurgitation.
Another question in which the image is again taken from Harrison's, we can see that in this, we can see the heart is shown, and in that we're taking a cannula, which is taken into the right atrium, and then from the right atrium, it is taken across the interatrial septum into the left atrium. Then, as you can see at the end of the guide wire, there is a balloon. This balloon is passed through the mitral valve, and then it is inflated. So as you can see, we are increasing the size of the stenotic mitral valve. So it is used for mitral stenosis. It is the percutaneous mitral balloon valvotomy, and it is known as the Ino balloon technique. This name is very important.
In this question, we are asking about the grading system used in angiographic assessment of myocardial infarction. These consist of grade 0, 1, 2, and 3. Grade 0 is complete occlusion of the artery. Grade 1 is penetration of obstruction by contrast, but there is no distal perfusion. In grade 2, there is perfusion of entire artery, but the flow is delayed. In grade 3, there is full perfusion and normal flow. This is known as the TIMI grading system, thrombolysis in myocardial infarction grading system. The TIMI grade 3 is the goal of fibrinolytic therapy. Grade 3 has better short-term and long-term survival outcome than grade 0, 1, 2, and 3. Tenecteplase and reteplase are superior to streptokinase in achieving TIMI grading 3.
Now we have a question on dermatomyositis. As you know, dermatomyositis is an autoimmune disease which affects both the skin as well as the muscle tissue. So there are various types of antibodies which have different presentations in dermatomyositis. So as you can see, we have to match the clinical feature with the specific antibody. So the first option is amyopathic dermatomyositis with severe palmar rash, vegetal ulcers, and rapidly progressive ILD. This is seen in patients having the anti-MDA5 or the anti-melanocyte differentiation antigen 5 antibody. So it is a straight match. Then increased risk of cancer is seen in patients having anti-P155 or the TIF1 antibody and the anti-NXP2 antibody. So it has two matches. And finally, benign dermatomyositis and having a favorable response to treatment is seen in patients having the anti-MI2 antibody. This is the answer to this question.
Now we have a case scenario, a 14-year-old boy presenting with abnormal jerking and disorientation. There is myoclonic jerks observed in limbs, poor school performance for past few months, and personality changes, along with the visual disturbances, loss of balance, and history of recurrent falls. There is no history of fever or headache, and the mother is not sure about the vaccination status of the child. This is a classical case of subacute sclerosing panencephalitis. This is a chronic progressive demyelinating disease of central nervous system. There is generally history of primary measles infection at young age and latency period of 6 to 8 years after which the SSPE occurs. The EEG consists of high voltage sharp slow waves every 3 to 8 seconds, known as the Rademacher complexes. As you can see in this EEG picture encircled, there is the Rademacher, classical Rademacher complexes. Now we put this question to emphasize upon the treatment of this disease. As such, there is no definitive therapy for this, but isoprinosine in combination with interferon alpha has been shown to improve the survival rate. Isoprinosine is analog of thymus hormone thymosin, and it acts as an immunostimulant, and it provides benefit in the SSPE.
Next question. So this question is slightly based on trivia. It is based on a story involving a horse called the Trojan horse. Trojan horse was a huge hollow wooden horse which was constructed by the Greeks to gain entrance into Troy during the Trojan War. Inside this hollow wooden horse, there were Greek soldiers. So the Greeks entered the area of Troy inside this horse, and then they emerged out of the horse to open the gates to let in the returned Greek army. A new antibiotic which was recently approved also utilizes a similar mechanism of action in view of increasing antimicrobial resistance. This is called cefiderocol, and its brand name is Fetroja. If you break the word Fetroja, it is Fen Troja. Fe stands for iron and Troja stands for Trojan horse. You'll know the importance of iron soon. This is also called as the 6th generation cephalosporin. It is used for complicated UTIs and multi-drug resistant gram-negative sepsis, including bacteria like Pseudomonas. Now, how it acts is, this is a Sidro4 antibiotic. It binds to iron and then it uses the iron transport mechanism of the bacteria to enter into the bacteria and then inhibit cell wall synthesis. The advantages of this antibiotic is that it bypasses the porin channels. And the porins are the areas in the gram-negative bacilli which have the maximum mutations for causing resistance. So the Sidro4, it binds to iron and enters the bacteria using its own transport mechanism. Therefore, it is called to be having a Trojan horse mechanism.
Now we have a question on myopathy again. There are various markers which are used in different myopathic diseases. The first is myxovirus resistance protein A, which is used as the marker of dermatomyositis. Then we have P62 immunostaining. It is used in inclusion body myositis, a distal predominant myositis like myotonic dystrophy. Then we have anti-HMG-CR and anti-SRP. HMG-CR stands for hydroxymethyl-luteryl coenzyme reductase, and SRP stands for signal recognition particle. It is seen in immune-mediated necrotizing myopathy. Then we have amino acid tRNA synthetase, also known as anti-Jo1 antibody. It is seen in anti-synthetase syndrome, a new disorder previously being considered of dermatomyositis spectrum.
Now, the next question was a connect question. In a connect question, you are given 4 to 5 images, and then you have to guess what those images stand for, and then find a single diagnosis to them all. Now, as you can see, in the first image, the parents do not have any disease, and then the disease is being transmitted only two male children. So therefore, it's a X-linked disease. In the second image, you can see there is dilation of the cardiac chamber called dilated cardiomyopathy. In the third image is mentioning here ANC, that is the absolute neutrophil count. And you can see the fluctuating course. This is called cyclic neutropenia. And finally, this child is having a short stature. This is an X-linked recessive disease called Barth syndrome, and it is seen due to mutations in a specific protein called the tafazin protein. So just remember this tafazin.
Now we have a clinical case scenario. There is a 8-year-old boy presenting with history of developmental delay and seizure since 6 months of age. He is a first child of third-degree consanguineous couple presenting with pinoscrotal hypospadiasis, dysmorphic faces, bulbous nose tip, small stubby hand, and central polydactyly with short stature. MRI picture of the brain is given. As you can see in the MRI, there is abnormal growth in the region of hypothalamus, most likely a case of hypothalamic hamartoma, associated with a syndrome known as the Pallister-Hall syndrome. This is an autosomal dominant disorder due to mutation in GLI3 gene. The clinical features of hypothalamic hamartoma, the classical gelastic seizures, and the precocious puberty are there. Along with, due to mutation in GLI3 gene, there are polydactyly, impurpurate anus, craniofacial defects, and genitourinary anomalies are also seen. So this is the case of Pallister-Hall syndrome.
Now the next question, also the clinical case scenario in which a 35-year-old homosexual man infected with HIV 10 years ago now presents with acute prosthetic left knee infection. He had a history of left femoral osteosarcoma, which was treated and resected, and in its place, a knee megaprosthesis was implanted. Now he has developed acute left knee inflammatory pain, swelling, functional impairment, and high-grade fever. He also has multiple skin lesions suggestive of cellulitis. On doing an aspiration of the joint, there was a turbid fluid containing 5,500 leukocytes per mm³ with a differential of 75% neutrophils. So it suggests a septic arthritis due to bacteria. The CD4 lymphocyte count was found to be 370 per mm³. It is less than 500, so the count is reduced. This is a typical case of septic arthritis caused into a prosthetic joint by Helicobacter pseudomonas or Helicobacter phenoliae. It is typically found in immunosuppressed patients like HIV patients. Especially, it was first diagnosed in people who were males having sex with males. It also causes concurrent cellulitis. So the diagnosis is pretty important in this case to know that the diagnostic, the causative agent is Helicobacter pseudomonas or Helicobacter phenoliae.
Now, we again have a case scenario, a 26-year-old primary gravida of 30-week gestation presenting with worsening non-pruritic jaundice for 1 week. There is no associated abdominal pain, nausea, vomiting, or fever, ruling out any hepatic pathology. There is no medical history except of few episodes of jaundice in her teenage, which resolved spontaneously without treatment. On testing, the hepatitis panel is normal, LFT profile is normal, and the total bilirubin is 4.2 mg% with conjugated bilirubin of 3.5 mg%, suggesting a direct increase in bilirubin. On further investigation, the urinary total coproporphyrins were found to be in normal limits and urinary coproporphyrin 1 was elevated. So this is a classical case of Dubin-Johnson syndrome, and as we all know, the classical picture of Black River. Arman, please go to the question. I want to emphasize that as you can see, the urinary total coproporphyrin is normal in this case. In Rotor syndrome, it is elevated, and the urinary coproporphyrin 1, which is elevated in this Dubin-Johnson syndrome, is less than 70% in case of Rotor syndrome. Now we can see the pathogenesis of Dubin-Johnson syndrome. The MRP2 transporter is used to transport the conjugated bilirubin outside of hepatocytes into the bile canaliculi. When this is mutated, the conjugated bilirubin leaves the hepatocytes through the MRP3 channel into portal sinusoids, causing conjugated hyperbilirubinemia. And there is black liver because of melanin pigment, which is also secreted with the help of MRP2 transporter, cannot be secreted anymore, which leads to accumulation of melanin and the classical picture of black liver.
The next question also had a clinical scenario in which a 55-year-old female of Turkish descent presented with erysipelas-like eruption, which was refractory to antibiotic treatment. The patient complained of pyrexia, episodic abdominal pain, fatigue, muscle and joint pain, and even chest pain. The skin lesion resolved after antibiotic therapy, but it kept on recurring locally. The patient had a CRP elevation and peripheral neutrophilia, with an undulating course with phases of recovery and direct aggravation. Always the aggravation episodes were accompanied with high-grade fever, which is important. A kidney biopsy in this case revealed amyloidosis. The diagnosis in this case is familial Mediterranean fever. This is an autoinflammatory syndrome caused by pyrin mutation, which leads to overactivation of the inflammasome, and overactivation leads to increased activity of the caspase 1 enzyme, leading to increased levels of IL-1 beta level, which causes all the inflammation. It is seen in patients with Armenian descent, Arabs, Turks, and Jews. Repetitive attacks of pleuritis, peritonitis, and arthritis are seen. Amyloidosis is seen due to chronic inflammation, and the dermatological sign in this case is erysipeloid erythema. Drug of choice for this condition is colchicine. Now, as we all know, colchicine is a drug which prevents microtubule polymerization and hence prevents chemotaxis of neutrophils and inflammatory cells. It is a good prophylactic agent. In the acute cases, we can also use IL-1 antagonists like anakinra.
This is a connect question showing ptosis. Second picture shows the clubbing of the digits. The third picture shows the migratory erythema, Trousseau phenomena, and the fourth image shows the seritinib, the tyrosine kinase inhibitor, the ALK inhibitor. So we can connect all these on, and we can arrive at a conclusion that this is a case of adenocarcinoma of lung. The Horner syndrome is caused by the Pancoast tumor residing at the apex of the lung. The second image, which shows the clubbing, is associated with case of adenocarcinoma of the lung. The Trousseau syndrome, which is classically seen in gastric cancer and pancreatic cancer, is also seen in adenocarcinoma of the lung, and it is also known as a migratory thrombophlebitis. And the fourth image, the seritinib, which is ALK inhibitor, is used in the management of this adenocarcinoma of the lung. So the connect is the adenocarcinoma of the lung.
Finally, coming to the last question. In this question, we have a clinical vignette in which is a 54-year-old female who was diagnosed with hypertension at the age of 26 years. She received up to 4 antihypertensive treatments, including a thiazide diuretic. Therefore, we can call it resistant hypertension. At the age of 52 years, she was admitted for angina with a normal coronary artery, where a severe hypokalemia was diagnosed. Renal artery stenosis was ruled out, and a CT scan revealed 2 centimeter unilateral left adrenal adenoma. On admission, there was tetany, U wave in ECG, and a low serum potassium level. As we all know, U wave is seen in the ECG in patients with hypokalemia, and the renin levels are also found to be low. So at this stage, we know there is a left renal adrenal adenoma, so we can safely make a diagnosis of Conn syndrome at this stage. But later, it was seen that when the patient had to undergo a 1 milligram overnight dexamethasone suppression test and a 2-day low dose dexamethasone test, the levels of cortisol were still found to be elevated, suggesting something related to a Cushing syndrome-like picture. But the patient didn't have catabolic signs, and also the ACTH level was incompletely suppressed, which would not be expected if the patient had Cushing syndrome. In Cushing syndrome, patient would have had catabolic signs, and ACTH level would have been completely suppressed. Pituitary imaging was normal, telling there was no pituitary adenoma. So this patient has features of Conn syndrome and features of mild Cushing's. This is called as a Cushing syndrome, also known as the mild apparent cortisol excess or MACE. Some of you answered the question as same, syndrome of apparent mineralocorticoid excess. It is due to deficiency in 11 beta hydroxysteroid dehydrogenase, which is used to degrade cortisol. Now, this cortisol will have increased mineralocorticoid effects, but the level of cortisol will not be increased, as is seen in this case. So, therefore, answer is not same, but Cushing syndrome. So, thank you for watching our video. I would like to end this by saying that we have become better in quizzing after attending multiple quizzes, and we request you all to participate actively in quizzes and improve your clinical acumen as well as your ability to attempt any question in examination.
We will be conducting a series of quizzes every week, and we will be uploading a video solution to all of the quizzes to improve your question solving abilities. We hope you to see in the next quiz. Thank you for the participation.
Thank you, everyone. See you soon. Bye-bye.